patellofemoral joint now. So we're going to be working on the patella, moving it laterally, medially, longitudinally, in both directions, both caudad and also cephalad. So when we're going for the medial or lateral, you always want to be trying to push it away from you because you have a little bit more power and a little bit more control. So if it's a lateral, I'm going to work on the opposite leg, so we'll just move the leg slightly towards me. And what we're going to do is we're going to come here and here, so hand above and below, so we've got something to grip hold of, and then the thumbs are going to come onto the medial border of the patella. Okay? In this extended position, the patella should be nice and mobile, so this is the best position to get accessory movements of it. Then on the side of the patella there, and we're then going to push it laterally. You can see it bulging out. So that'll be our test range, and obviously we'd have a grade 1, grade 2, grade 3, into resistance now, and grade 4. Obviously, if anyone has any apprehension tests in terms of a positive apprehension test outcome, in terms of patellar dislocation or any sort of history of any of that, then you wouldn't want to be doing this necessarily as a treatment. For medial glide, it's coming onto the side closest to us now, so now we're exactly the same handling, thumb now on the lateral side, and now we're just going to push the patella medially. This is the most likely direction you're going to need to move the patella. So we test the range, grade 1, grade 2, grade 3 into resistance now, and grade 4 towards the end of range. For longitudinal, we come onto this side just to show you as close to the camera. We're going to go to the foot end of the bed. We're going to be applying the pressure upwards and towards the head. So what we do is we're going to come onto the inferior pole of the patella, and my fingers are just going to support medial and laterally just to guide it. So from underneath here you have to press down slightly into the patellar tendon, and then we're going to glide the patella upwards. They feel a little bit of resistance, or you feel the resistance. You can come back, and then you can do your grade 1, your grade 2, grade 3, coming to resistance now, and grade 4 towards the end of range. For longitudinal caudad, I'm going to come onto this side, so certainly if I was going to do this leg, I'd be on that side. Again, same sort of thing, guiding with our fingers here, thumbs in the very top of the patella. What you're going to do is you're going to glide it down. Now, some people actually can glide quite a long way, it depends upon the flexibility of the quads. I don't think Neil has particularly lax quads in this sense, so we're probably not going to get too much movement. Okay, so we press down and then we glide that patella down, start to go with us, we're going into the end of range, so it goes quite slowly, sometimes you might feel slight crepitus, end of range. Okay, we're going to come back, so we've got a grade 1, grade 2, you won't be able to go too fast on this one, definitely, it keeps you slow, this one, grade 3, grade 4 at the end of range. Wherever possible, you should also advise your patient if they feel any pain, to tell you and to try not to tighten up their quadriceps, because if they do, they'll pull that patella up very violently and quickly, and that can cause quite a lot of discomfort underneath. As we mentioned before, for the patellofemoral joint, quite a common mobilisation we need to do is a medial glide. This can be because of the tight structures on the lateral side, in particular the retinaculum coming in from the iliotibial band, where it has a common insertion point via that. So these lateral structures, if they do become quite tightened and shortened, they may therefore need to be lengthened. So in this position we can alter the positioning of flexion to around about 30 degrees or so of flexion. You can alter that as well and gradiate it between 30 and 0. And then what we can do is, because we've got a certain amount of hip adduction here, we're actually putting the iliotibial band and the TFL on a slight stretch. By doing that, when we apply our mobilisation, which is going to be very tight, you're not really going to get a grade 1 or a 2 in with this technique, you will be able to influence the stretch of the tissues that are tight from this position. Functionally, therefore, it's also more important because it's towards our degree of flexion. So this is kind of making the manual therapy technique much more functional in what we're trying to achieve. Because of this position, we also need to change our handling slightly. We're going to use this part of our hand here. We're going to grip onto the medial side. We're going to support the knee with our other hand and apply the pressure straight down there, coming across the knee. Okay, so what you will find is there is literally zero resistance-free range, so it's impossible to do one or a two. We can apply our force there, obviously checking with our patient for any pain at all, and then we can apply, for instance, a grade 3, or indeed a grade 4. Obviously here I've got a towel underneath. We can adjust this, adjust the position to get it into the ideal position to get the right amount of stretch that we need.